good. How are you doing today?
Good, good. We're here to learn a little bit about ceramic implants. So I see that you have an X-ray from a patient loaded. Let's go and talk about your technique and how you were able to help this patient.
Absolutely. Well, you know, this patient came to me from out of state. He found out that I was placing these ceramic CeraRoot implants, and for his decision, he felt like, you know, ceramic implant was the best option for him restoratively. And when I saw him, he was suffering with root canal molar teeth that were failing. There were infections in the roots. One of the teeth had actually cracked. And so we had to go through a process of extracting the molar teeth, the ones that were failing, extracted those. Then we did some bone grafting procedures to regenerate the bone. And then after about 4 to 6 months of healing after the bone grafting, I was able to go in and start placing the ceramic CeraRoot 16 implants. And they were not all done at one time. They were staged out over about a 1.5 year period of time of treatment for him, where we restored to completion the patient's right side first, and as you can see from the X-ray, we're in the process of restoring the left side. But the technique was basically extraction of his molars, followed by bone grafting procedures, socket preservation, and then 4 to 6 months of healing. I was able to go in and place the implants. We let the implants integrate in like we typically do for the lower implants on the mandible, usually 3 to 4 months. And our maxillary implants, we tend to let those heal anywhere between 4 to 6 months, depending on the stability of the implants when they're placed, depending on the healing of the patient. Several variables, but typically between 4 to 6 months of healing on the maxillary implants. Yeah, this patient was incredibly happy and satisfied with the entire process. The implant surgical procedure was very simple and straightforward. All of the implants that I place here in this office are guided through a virtual surgery beforehand. Every patient comes in, they get a CT scan to evaluate the quantity of bone that's available, and then a guide specific to that particular patient is made, so I know exactly where that implant needs to be placed prior to the procedure. And these implants are placed very precisely through a very small, minimally invasive technique where we make a small little punch incision in the gum tissue, remove just a tiny bit of gum tissue, gives us access into the bone. Our drills are very, very precise and accurate. I know exactly where I need to place that implant, and the implant is done, and patients can go home without usually any kind of sutures. There's very little bleeding, very little postoperative discomfort from this, and most patients are able to resume their normal activities that same day. This is about 3 years of use for me. I started using the ceramic implants after I had several patients come into my office requesting a ceramic implant. It started my investigation into the different materials that are available for implants. For patients who are desiring a more natural type of implant. Some patients who just have metal allergies or concerned about implantable metal devices. So the CeraRoot ceramic implant is a great option for patients, and that's what initially got me started on using the CeraRoot implant. After I placed several of them and I recognized the ability for the body to heal wonderfully around these implants, I was able to see how well the bone was maintained around the threads of the implant and how beautiful the soft tissue, the gingiva, responded to these implants. It's become more of a mainstream implant in my office, and I am offering the ceramic implants to all of my patients, whether they're requesting them or not, whether they're looking for a more natural way to replace their teeth or they're just interested in implants in general. We're offering at the office now the ceramic implants in the anterior for more aesthetic cases, in the posterior for better stability and support, and lower bacterial risks using these particular types of implants. Well, one of the most significant things that I see is the soft tissue response around the implants. With a titanium implant, oftentimes it integrates just fine. I mean, we have a success rate that's probably upwards of 95% success with titanium implants. But what I see mostly is the response of the soft tissue. And when we're dealing with either the soft tissue in the anterior, where it's a more aesthetic reason for replacing the teeth with implants, or in the posterior for the masticatory support around the implants, I see that we are able to maintain better keratinized tissue. The tissue doesn't seem like it's inflamed or irritated like it can be around the titanium implants. It looks like we've got better attachments of our soft tissue around our implants as well. So I'd say the significant difference between the titanium and the ceramic has to do with how our soft tissue responds to that particular implant. Well, you know, I think overall the failure rate is fairly similar. I've placed hundreds of ceramic implants, and I can think of 2 failures that I've had. I've placed a lot more titanium implants in my career, so there's obviously a little bit more, the number of failures are a little bit higher, but around a 95 to 97% success rate, I would say, is what we're looking at as far as the failure rates of the implants. Maybe 2 to 5% failure rate on these implants. Of the 2 ceramic implants that I know that have failed before integration, it was due to premature loading of those implants. It had nothing to do with the ability of the implant. It was just that those implants were loaded prematurely, and of course if it's a prematurely loaded implant, it's very likely to fail. You know, restoring a ceramic implant like a CeraRoot is much easier to restore than it is a typical titanium implant, and that's because this implant is a one-piece implant, meaning the implant and the abutment are connected together, and the implant comes with a machined finished margin. So as a dentist or restorative dentist, if they are concerned at all about how to take impressions, I let them know that it's just like you take a regular crown impression. If you need to pack a little cord in order to be able to see that clear margin on the abutment, that's what you can do. 99 times out of 100, there's no problems at all taking impressions, and it's just a typical, regular crown impression like you would on a natural prepped tooth. No, it's very infrequent to have either the crown become uncemented or the implant to fracture. In fact, I've never had an implant that I've placed that's been restored that's ever had any problems with fracturing. I have in the past temporarily cemented crowns on top of an implant, a final crown with temporary cement, and that's come loose a few times. But anytime I've used a permanent type cement, I've never had any problems with that crown coming off. I certainly hope so. I think that in implant dentistry, we've kind of been in a stationary moment of time for quite some years now, where we have introduced in the root form implant, which is a great titanium style implant. Now we're doing some modifications to the surfaces of it, sometimes the internal connection with platform switching, but overall it's basically a titanium screw in which we can attach different kind of components to it to restore. I think with the introduction of the newer materials, the newer ceramic materials that we have that are more stable, solid, less brittle, less risk of fracturing like we had in the past, I think we're moving into a new era of implant dentistry, and I think the ceramic implants are going to break out in the next couple of years as the implant of choice for people, not only for an aesthetic purposes, but for functional purposes, and also just for the body's ability to heal and maintain its support around those implants. Well, I'm not nervous at all, actually. I'm very much looking forward to the procedure to have my implant placed, and I have chosen to have a ceramic implant placed for myself. I'm missing an upper left first molar, so we're going to use a CeraRoot 16. today to place that implant in. I'm also going to be needing to do an internal sinus lift as part of the procedure, where we're going to lift up the floor of the sinus slightly so we can put a little bit longer of an implant in. I've got great confidence in the surgeon who's going to be placing the implant. I've got great confidence in the implant itself, and I know that my body will respond very well to it, and in a few short months I'm going to have a nice beautiful zirconia crown on top in order to function and restore this missing space. So yeah, I'm excited to get started and to get my implant.
Okay, so let's go for it.
All right, let's do it. Okay, let's do it.
All right, I'm ready.
Actually, no, I might have you go up further than that. So I'm going to actually have you go to the 4-5. Okay?
When did you start doing PRF and blood draw?
Oh man, I've been using PRF for about 10 years.
Okay.
Yeah, at least 10 years.
Okay, and it doesn't matter if it's healed sites, or most of the times it's more immediate cases.
No, I use it all the time. I use it whether it's with for my extractions and bone grafting cases. I'll mix it with the bone, and then when I'm doing an implant, I'll also coat the surface of the implant with the PRF. So yeah, I use it all the time. And wisdom teeth extraction sometimes.
And do you make some kind of fabric membranes around the implants?
Yeah, what I'll typically do is when the when the fibrin coagulates, then what we'll do is we have a little box to press the clot down, and I'll use the liquid, decant the liquid off to coagulate or to reconstitute the bone. I'll take a fibrin clot and I'll coat the surface of the implant with it, and then typically I'll lay either another clot either over the top or around the neck of the implant.
Do your sinus grafts come most of the times from crestal approach, or with what percentage would you say you go with a lateral window?
Maybe 20% of the time with a lateral window. About 80% or more of the time we try and do a crestal. If we have about 4 millimeters of crestal height, then I try and do it through a crestal approach as opposed to lateral window. And obviously if I've got multiple sites in the posterior, multiple sites, then I'll be a little bit more aggressive with a lateral window as opposed to, multiple crestal approaches. But typically if it's a single site like this, it'll be through a crestal approach.
And for a case like yours that you have like 7 millimeters of bone, how much time you would feel comfortable waiting before the crown?
6 months. Yeah, I mean, it depends. I'll take an X-ray at 4 and see what it looks like at 4 months, and if it looks stable, sounds stable, and then we may, restore it a little bit sooner than that. But I'm okay to wait 6 months for it.
Okay.
Yeah, no, I mean, obviously I recommend tobacco cessation for all of my patients, whether or not, we're doing an implant or we're doing an extraction. However, I understand that for some people, quitting smoking is not what they want to do or an option for them. So I recommend that during the healing time, initially the first several days post-operatively, if they're able to not smoke, it's going to heal better for them. Let them know that there's a higher failure rate with our implants in people who smoke, because that's just across the board, higher failure rates. So sometimes it's good motivation if they're investing the money in restoring their mouth with implants. That's oftentimes a good motivator to get people to stop smoking. And then there's, obviously different techniques that we can offer patients and medications that we can offer to help with tobacco cessation as well. But yeah, ideally, you want to have your patients not smoking during the healing, but understand that it's not always a possibility for that to occur. So the typical postoperative protocol is a 2-week follow-up, post-op follow-up, and then if everything is healing well like it's supposed to, I typically don't see the patient again until the 3 to 4 month mark, depending on whether it's a mandibular or maxillary implant. And so I'll see the patient back 3 to 4 months later. We'll take a postoperative panoramic x-ray to evaluate the integration of the bone, evaluate the soft tissue. And if things look great, at that point in time, then the patients are ready to be back to their restorative dentist for the final crown.
Very good.
Actually, with the ceramic implants, we tend not to get phone calls from patients with postoperative pain issues. And I think, part of it has to do with the biocompatibility of the implant with the bone and soft tissue. And I think part of it also has to do with the protocol. In order to put the implant in, it requires much less torque values putting the implant in. And so we don't see patients complaining or having much discomfort. There's not the pressure in the bone that sometimes you feel with more of a tapered implant that can generate higher torque insertion values. And because the majority or almost all of our implants that are placed are all guided implants, we don't see a lot of discomfort from the soft tissue because it's done usually through a very small little punch incision, a 5 mm diameter punch. So we don't see a lot of soft tissue swelling, and so patients don't really have a lot of postoperative discomfort from these procedures. So normal return to oral hygiene is typically a week after the procedure is over. They can certainly brush, all of the teeth except for the teeth on either side of the implant after the first day. But I usually let them wait about a week. So if there is any soft tissue swelling or any, if I do have to put sutures in very infrequently, then we let all that soft tissue heal, and then they can start brushing about a week or so after surgery. They can brush the interproximal spaces between the implant. And then patients also can be prescribed a Paradex mouth rinse that they can either use as a mouth rinse generally, or oftentimes they'll just have them apply with a little Q-tip around the implant site. They can put a Paradex on a tip of a little Q-tip and just apply it around where the implant is to cut down on the bacterial load. But one thing that I don't see a lot of actually is accumulation of plaque on the transgingival portion of these implants. Occasionally, if a patient's a heavy plaque former, then you can see some plaque and debris that gets built up on the abutment portion of the transgingival portion. But many times when patients are back, 3 months, 4 months, 6 months down the road, when they return, their transgingival component, the abutment portion, is in pristine condition. We don't see bacterial plaque that develops on it. So it's a very bacterial static type of material as well. It doesn't encourage colonization of bacteria.
Perfect. Very good. It feels good?
Sweet, no problem. It was
Okay.
great, easy.
Perfect.